Well, good afternoon, everybody, and welcome to today's session of the Children and Adults Health and Wellbeing Policy Development and Scrutiny panel. Can I just remind everybody to ensure their phones are on silent, and also to ensure that when they are speaking that they press the appropriate button on the microphone, because not only will we be able to hear your voice, but also the camera will focus on you too, which will be good for the webcast. And in a similar way, when you stop speaking, if you could turn your microphone off, then the camera and microphone will then move to the person who's next speaking. In the interest of time, because we've got a relatively short amount of time and a lot to cover, I'm going to dispense with our normal introduction part, but perhaps if it's the first time you're speaking, if you could just introduce yourselves, that would be helpful. For the benefit of any public that are watching, this is a mixture of councillors but also non-voting members who are co-opted onto the panel, and I will now move to the agenda. So, thank you and welcome to everybody. Mark, could you tell us what to do in the event of an emergency?
Yes, certainly, Chair, no problem. If the continuous alarm does sound, we must evacuate the building and proceed to the assembly point. From this room, we follow the green running person signs to the exit, using either the marble staircase or the main staircase. Please do not use the lifts. The assembly point for this building is the Orange Grove grassed area just outside Brown's Restaurant, and there is an evacuation chair for use by disabled people who so wish in the corridor outside the Council Chamber Public Gallery. Alternatively, the area at the top of the marble staircase has been designated as safe refuge where persons needing assistance should assemble. Thank you, Chair.
Thank you very much, Mark. So, having said everyone should introduce themselves, I've rather failed to do that myself. So, my name is Dina Romero, and I'm a councillor and a voting member, and I chair this panel. So we now move on to apologies for absence and substitutions. I've received 3 apologies from Councillor Senai, Kevin Burnett and Councillor Pankania. I believe Councillor Crossley may be late, and I do not believe we have any substitutions. If I've missed anybody who ought to have apologised, then please let me know now. Otherwise, I shall move on. Okay, declarations of interest. I have not been notified of any, and there is no urgent business to declare. We now have public and councillor statements and questions. I've not been notified of. I have been notified of one, but I believe that member of the public is not here. And Councillor Jackson. Okay, then I will turn to Councillor Jackson, who will make her statement.
Chair, I had arranged to speak before the item because that seemed more appropriate, if that's acceptable to you.
That's perfectly acceptable. Do you remind me which item you wish to speak to?
It's the suicide prevention report.
Okay, thank you. You know that that's at the end of the agenda. Okay, lovely. You're more than welcome to stay until then. Right, we now move on to the minutes of the 14th of October. Can I have any queries or any inaccuracies raised?
Thank you, Chair. I'm Liz Hardman. I'm the Ward Councillor for Porton, and I'm Vice Chair of this committee. I did raise 2 items with the Integrated Care Board about the Ocean website, and I'm wondering if I could, when we come to that item, when we come to your agenda item, Laura, if you could mention that, and also about maternity midwife provision and the fact that we were told that it was at a very kind of difficult level. There were lots of shortages, and I was wondering if you could comment on that as well. Thank you.
You want to wait until your item, Laura, to comment on those?
I can. I suppose what I wanted to say is that I don't have a formal update today, but we're looking to get you written updates because I understand that you also wanted the data to support the midwifery information. So we don't have that update today, but we absolutely have that as an action in hand.
Okay. Thank you. So are there any other inaccuracies? Leslie.
Thank you. Leslie Mansell, Councillor for Radstock. On page 6, Councillor Jackson had made a statement regarding access and planning, and I did ask at the end if she thought that if the council adopted the social model of disability that might be helpful, but it hasn't been recorded in the minute.
Thank you, Leslie. Can we ensure that the minutes are amended? Yes. Okay. Leslie, is there other points you wish to raise?
No, I'll raise it as part of the business. Thank you.
With those amendments, can we vote on accepting these minutes? Everyone happy? Yeah. Yes? Okay, good. Right, so I believe those are passed. We now move on to item 8, which is the community support contracts update. And so we have received some information, but I'm looking forward to hearing the presentation from Kate and from Suzanne. I understand that Becky Brooks is unwell. Okay, do you want to use... a technical moment? Okay. Your knight in shining armour is on his way.
Suzanne Weston, the Director of Adult Social Care.
I'm Kate Morton. I'm the Chief Executive of Bath Mind and the Chair of Baines 3SG.
And today I was due to present with Becky Brooks, who is unwell, so she sends her apologies, and she's very disappointed she won't be here. It's me, Becky. She won't be here to present. So, there are some slides, and I'm not going to go through them page by page, because I know you'll have read them. What I have done is set the scene, and just talked a bit about developing the case for change, and then the engagement and next steps. So I'm just going to remind us where we were, and then I'm going to hand over to Kate, who's going to talk about the engagement events, how they went and what came out of those, and also where we are in our next steps. So just to remind you that one of the reasons that we have found ourselves in this position is that we've been working with the third sector to ensure that following the HCRG subcontract, that the Council on the 1st of April will be taking over the overall contract. So we found ourselves in a position where we were reviewing the contracts anyway because they were ending. And also, you'll remember that there was a savings target up against it, 802k, which was across adult social care and housing. They were the two drivers for change, if you like, about improvement, quality, support, and making sure that the sector got the right support, and also that we were able to deliver on our savings target. If you remember rightly, the last time I came, Becky Brooks spoke to the panel and said how unhappy she was with the engagement or lack of engagement she was having with the Council, and there was a sense of not hearing what the Council was doing and saying, and not engaged in our commissioning intentions. And Kate will talk a bit about that. Just as a reminder, our contract is all around our Care Act compliance, which is listed in slide 2. The other reminder I wanted to give you was the funding. The funding allocated to this contract across the Council, the ICB and the BCF is 3.4 million. So you'll see there's 3.439048 million. That's what's allocated at the moment across the contract from the local authority. And you've seen the breakdown. Some of that is in the BCF. And just a reminder about the Better Care Fund. Better Care Fund, the Better Care Fund, we're on the second year of the Better Care Fund. We're waiting for the national picture around the funding of that for the following year. We don't know how that will work, and we'll just be going into the second year. So it'd be interesting to see what government decides to do on that. Now, commissioners have been very busy, looking at baselining the contracts, looking at the services on the pages, looking at everything we have in place at the moment with the voluntary sector, so that we've got a baseline of where we are and where we want to go. Finally, just to talk about the key areas that we think are really important now is around better information and advice. We have actually very good information and advice, and if you think about the work we already do with the third sector around a community hub, you know, it's outstanding. We really want to focus in on prevention and actually that left shift, and you've heard about this in the Darcy report as well. Really want to see some changes in there. Carers are very important for all of the sector and for the council. So I'm not going to go through all of those, but the contract baseline had 8 areas, which you'll have seen in the paper. And really, there's nothing more I want to say at this stage. I just wanted to give you the baseline, say where we are, and then you asked us on the, I think it was the 9th of September, to go away and do some joint work. And that's what we've been doing since we were last in Scrutiny. So I'm going to hand over to Kate now.
Thanks, Suzanne. So Suzanne said since the 9th of September at Scrutiny, when we presented our concerns, and we've been working really closely with the council, which has been really good, so that kind of co-production and collaboration. We've, and you'll see from the slides, I'll try and be very brief, but two market engagement events have taken place. The first one on the 24th of September, which was looking at working with incumbent third sector providers who currently hold that community provider contract. And on the 8th of October, a market engagement event which was open to wider partners across the country. So that was kind of opening that up. We had 36 in total, 12 from incumbent providers and 24 from people who currently don't provide services in Baines but have expressed an interest. We then held 2 follow-up sessions which were facilitated by Stowe King. They are local sisters, those of you who know them, and they really are experts in the whole of the procurement process around the legal framework, around what is required, what the process looks like, how you can make arrangements for non-for-profit organisations. So they facilitated these 2 sessions. The first one was just with council commissioners, and the second one was with third sector providers across Baines, so it was open. And they were both very well attended. They were both very well received by both commissioners, but also us as third sector providers. And just picking out some of the key themes that came from the event, the feedback from colleagues across the sector. Really the importance of that shared vision and that shared purpose. So we work together with that one voice, and that we are all on the same page when we're delivering provision in the future. Looking at our alignment with ICB, and they're recognising there are challenges between system and place and how we can bridge and align that better, because that is currently still quite challenging, I think, for all of us in the space. We are public benefit organisations, and we need to recognise that and what that means for everybody. That equality of partnership, and how the needs of both the third sector and council need to kind of come together. So it's about what's that meeting in the middle. The requirements of our strategic partnership approach. Looking at where the council has lacked appetite for risk, if you like, so kind of sharing some of that risk together, and the fear of challenge. How can we work differently together to build some risk in, do a bit more bold and brave work, and the need to move from transactional to relational arrangements and contracts, be more open about our approach to procurement. There were concerns around the kind of subcontracting of nationals to locals. So if you award to a national, will you then subcontract for local? I know that's been a concern here, and I've spoken to some of you about that before. And that was something that Stowe King was very robust on, about how we can work through that process. And as Suzanne says, Community Wellbeing Hub was a great example, a great model of how we've worked really well collaboratively. the power structure is very clear. There is no power structure, and we are very, very aligned and collaborating, and that was kind of a real positive process as well. So assuring agility, assuring equity, assuring trust, openness, and working very, very well together. So those are some of the kind of key feedbacks. So the next steps. So what we want from this is what now? Where do we go with this? We want to continue with our relationships, continue with all the positivity that we've developed over the last 2 or 3 months. And so we're looking very much at the next steps. And some of those really are around scoping models around the country where it's working really, really well. What's the learning from other areas, other authorities, and doing that research. Developing commissioning models that are more collaborative and working really, really closely together. Looking at themes of the 2 market engagement events to develop a community support model that it is again robust and open and something that we are all signed up to equally, so it's not again that power differential. Developing some commissioning intentions going forward, so we're absolutely clear about a future plan from 25-26 onwards, so we're not just leaving it as it is, we're actually tying it up, as I sort of call it, closing the loop. And always continuing to engage with service providers, and I would add to that residents of Baines as well, making sure that co-production is really truly being developed and that we are asking our residents what it is that they want from their services across Baines. And making sure that that kind of further community support arrangement is being organised. And one thing we also said, we want a further meeting just to kind of tie up and sort of summarise where we are, look at what the art of the possible is, how we can do things differently, and how we can do things safely, and what can we achieve that's legally allowed, but being bold and brave at the same time. So trying to kind of align those 2 elements as well. So that's where we're going from today. I don't know if you wanted to add anything, no, Suzanne.
Perfect. Thank you.
Thank you.
Can I say how positive it is, I think, for the panel to hear about that collaborative work that you're doing, and to actually have that shared presentation, I hope gives us a lot more reassurance than we might have had in the past. Anyway, I open this moment up then for others to ask any questions. Liz.
Much, and thank you very much for what sounds like a very positive partnership which is ongoing at the moment, but it doesn't really tell us anything about what's happening. So what's happening about these services that 3SG, that the voluntary sector are going to provide for us? I mean, we haven't been told when contracts are going to happen, and I think Julian House has mentioned that, you know, it may well close because there's all sorts of problems about the lease and where it's going to go. So what is happening about our voluntary sector? Bearing in mind, I think it's been raised somewhere, that they can operate more cheaply than the council, that they can raise money from other areas. So just throwing all this in to say, so we are assured that things are ongoing and are becoming organised, but what about all the other voluntary groups? And we've heard that many of them don't know what's going to happen in the future. So, so my question is, so that sounds very good. It sounds very good for the future, but what is happening? And if I can put forward a question from Kevin, who's absent, but is not absent from questioning. He sent us all a list of questions. And he said, could we have a revised timeline of when the commissioning model will be completed, when the new contracts will begin, and what, if any, will be the implications for the 2025-26 budget? So, Kevin, I'm asking what happens next. You know, he's asking, what's the timeline for of when the commissioning model will be completed? When will the new contracts begin? And what will be the implications of the 2025-26 budget? So, thank you.
Thank you. We're both going to speak through this. First of all, around it's a very good question around the contracting. So, for this year coming, as I will say, from April 2025, we will have bridging arrangements with all of the partners, and we're working through that at the moment. So our commissioning team is working individually with each of the providers. We are generally saying the same as, unless a number of partners have said, we want to do it in a different way. We want to try this, we want to do this. So there's about 4 or 5 who want to do things a little bit differently. So obviously we're going to do that. So there's a lot of work going on for the year coming. We're expecting by September next year, 2025, that bridging arrangement will be done and we'll have the new contracts in place. It all depends on the work we're doing now, though, I have to be honest with you. And we've got to make sure we get this right with our providers. I would say what has made it quite difficult for us is the new national insurance. The national insurance, my expectation was contract, same value, no uplift. But actually, what the third sector have found themselves in a position is they're going to have to pay national insurance an increase from 13.8 to 15%. Now, Kate knows this so well, and she can give you verse on this, but that has changed our approach, and that's one of the questions that partners are now asking us. How are you going to support us with the changes? So, like for like, and a further discussion, but I think it would be helpful also to get a revised timeline in here to the next time we're here, because we're working through a timeline at the moment, and we can certainly share that.
Thanks, Suzanne. I guess just Liz also wanting to send some assurance that I wear 2 hats, as you know. So with my 3SG hat on, we are working really closely with all of the 240 third sector providers across Baines, and they provide all sorts of health, social care and other services, and we're working really closely with them. There's weekly updates, and they're involved in those sessions, and we'll be holding a very big session in the new year to bring them back together to keep them informed of where we're going. With my Bath Mind hat on, like Julian House, we obviously have lots of contracts. We are concerned, but we are feeling positive that we're working well with the council and that we're at the table influencing and making those changes. We don't feel done to in the way we were feeling back in, I think, February, March, when we were sharing with you our concerns. So I think it's very much about watch this space. It's taking a journey. We are working forward on this, but the positivity, I think, is the timeline has shifted, which enables us time to make those changes.
Just to follow up, hopefully there will be exemptions. The new government has brought in
what the employers
with national insurance.
Touching wood, yes.
So I'm hoping that will happen. But thank you for the clarification. That's really good. Thank you.
And I think I'm sure we would like to have a continuous update throughout our next meetings as well. Joanna.
Thank you, and thank you to hear such positivity from you both. Could you tell me a little bit about what the open book approach to partners means in this presentation that you sent to us?
Thank you. So, with our independent sector, so our commercial sector, when we're working through a financial issue around maybe they're looking for an uplift and we're not understanding why they need an uplift, we ask for an open book. So that means we look at all of their finances, we look at their profit margins, and we look at what areas that they need extra support in, or actually whether they do really require that uplift. The approach from the third sector is about, we need to understand where the risk areas are for them. I just talked about national insurance. That's a good example. Some of them are holding pressures on buildings. Yeah. And leases. So it's that sort of approach. So it's a much more open book approach. You see their finances, we share with. It's a well-tested model.
Okay, but saying that there's 230 private sector groups, that's third sector groups. Thank you. that's an awful lot of open books to be looking at and to be administering in terms of the council. So how do we have that kind of ability?
Yeah, that's my fault actually, sorry, slightly confusing. In terms of the current community providers, there's only 36.
Still with 36 providers, that's still an awful lot of looking at
absolutely.
an
We
awful
wouldn't
lot of
expect to look
numbers.
at 36. We would look at the ones that come to us and say, you know, that we're under pressure, there's a problem, we need your help. You wouldn't look at all 36 because some might be very happy with the allocation, say, yeah, this is all great, this is working very well for us. So you wouldn't.
And within the council, do you go to the accounts department to do that piece of work? I mean, who does the looking?
Commissioners do that.
Okay, thank you.
And, you know, they're well skilled in that, they do that regularly.
Leslie.
Yes, thank you for the report. A couple of questions I wanted to ask. I'm not clear about the timeline at all. I can't see it in here. Maybe I've just missed it. So could you explain a bit more about what the timeline is? On the health inequalities, emerging codes for change for community support, what information do we have about the impact of the social prescribing across BAMES? Because clearly that's important, and that's bringing up quite a number of things I think we probably ought to be looking at in the longer term. And also, with regard to the number of providers, what opportunities are there for some collaborative working rather than organisations working in silos and then finding it's a real struggle? Thank you.
If I just take the social prescribing and the silo working, if I may, and then hand to Suzanne. So first of all, we have been commissioned by Public Health, the third sector have been commissioned by Public Health to carry out a 2-year review of social prescribing across BAMES. And we've employed somebody who's leading on that at the moment, and we're nearly through the first year, and we're developing a framework, and we'll be presenting that. We can always bring that here, but we're presenting it to Health and Wellbeing Board, and that is going to look at the future of social prescribing along with the contracts of the third sector, because you're absolutely right, they're aligned, and as part of that pathway of the journey for somebody, ensuring that social prescribing keeps people well in the community and avoids hospital admission and that kind of deterioration of ill health. So it's about developing our social prescribing framework and what we mean by that, what we need, what are the what's the language around social prescribing, who's delivering it, and that's the piece we're doing in with this piece of work, so it's well aligned, and the two are talking together, and luckily the lead of social prescribing sits within 3SG, he's employed by them. So Becky, who's director of 3SG, can have sight of both. She has that oversight, so that's that. And then the silo working, you're absolutely right, one of the things that we want to achieve in this process is to ensure there's no duplication and that we're dealing with silos, that we are aligning better on the services that we're delivering across BAMES, and that there's greater transparency and socialisation, but we're also ensuring that where there is repeat work, if you like, where there is duplication, we're being more effective and ensuring that we don't deliver the same thing twice. So we're absolutely being more efficient.
Thanks, Kurt. So,
Just come back on that briefly.
Yeah.
You mentioned a report's going to the Wellbeing Board. When is that? When will that be?
That's a good question. I'm hoping, Becky, I'm hoping that we can finalise the framework and we'll aim for the February Health and Wellbeing Board. But if it needs to come here too.
so there's a
Will we
reminder
consider
around
putting it on our agenda?
Yeah.
So a reminder around the timeline was one of your questions. So we're expecting to come back to scrutiny with a timeline. We would expect to have all this done and dusted by September 2025. That's what we're working to. So we'll be out in a specification, whatever that looks like, early in the new year. But I've agreed that I would come back with the timeline, a more detailed timeline. I just wanted to go back around collaboration. The third sector already do that really well. If you think about the work that goes on between Bath Mind and Age UK, they do an awful lot of that. The work we do with the Bath Ethnic Minority Group, lots of work going on in the hospital around collaboration and a real focus. The Health and Wellbeing Hub is all about collaboration.
Yeah.
What I would say in the new specification, or whatever we call it, there is an encouragement about collaboration and back office functions. So there's an opportunity to have more frontline staff and less back office functions. So that's the sort of thinking we're doing at the moment. Yeah.
Thank you. That's really positive as well. You mentioned Bath a few times. What's happening out in North East Somerset?
So the organisations such as Bath Mind, we do work across the whole of Bath and North East Somerset. The name of the organisation needs to change.
Good point, actually.
It's a very good point.
All of our third sector
We
work
all work across, yeah.
Yeah.
We all work across North East Somerset. We're not just Bath-centric.
Kate, thank you. Ruth.
Yeah. Can you hear me? Yes. So I'm Ruth, and I'm one of the Western Ward councillors, and I'm a voting member on this panel. So thank you for your report. I just wanted a couple of things just to ask you about. One of the points you said that came out was that processes were often overcomplicated, and that you would be aiming for less transactional and more relational. Could you say, maybe you could explain that a bit? I think you sort of have, but just to kind of explain the terminology. And then I was also interested to know, you were saying, you know, about, as with lots of other areas, it's always good to look and see how other areas and people, organisations do things. So where have you been looking specifically, which authorities, which parts of the country, possibly abroad even? Thank you.
Yeah, so some of us have been talking extensively to other local authorities and third sector providers across London, lots of London boroughs. I'm quite in contact with a lot of people across the north of England. There's some great examples in Greater Manchester and in York, and in more rural areas in Derbyshire and to London boroughs, where they are doing that more relational. So it's very much about a framework, having access to funds, so we know what the outcomes-based model is, rather than being really prescriptive on the specification. That's the difference.
Okay, and I was just going to add, when you asked about transactional and relationship, what we would have previously done, gone out of specification, not really engaged with the sector, because we had our key commissioning arrangements in place. What's different this time is that we're developing what the commissioning arrangements will look like, what the specification when we get to it jointly, then we go into a procurement if we decide to do that. So it is much different how we're developing it, and that's what's actually slowed us down as well, because, you know, to have that relationship about what the market is thinking. And another good example of that is, how long do you do the contract for? Do you do it for 3? Do you do it for 5 years? Do you do it for 7 years? You've got to think about what that will look like for the sector if they're bidding for leave it too long. So the conversations that we're having, which previously we wouldn't have had actually. We would have just went out on our specifications, on our the expert information we had. The only other thing I would say is we're working with Richmond, who's done some really good work around carers and how they've awarded the contract. You know, we've recently awarded a contract anyway, but with more work to do there. And the other area is Leicester. They're the two areas that we're particularly working on at the moment. But actually, the third sector have been out there and talking to loads of different people.
Joanna.
One of the things that we're always told is that there are statutory duties of the council. This committee has never actually sort of had a list of what that statutory duties are. It would be really useful if we could have a list, so we have some idea of what this council at all times is expected to deliver. What is that baseline?
Is that something you can... Yeah. So, Mark, is that something you can provide?
I'm sure we can look into finding that information, Chair, yes.
We'll make sure that that's available for you. Okay. Alison.
refer you to the presentation and the slides, and one of them's got the Care Act duties, 2014, so that's the responsibilities under the Care Act.
I think with many services, it's when things are not set out in sort of as statutory, that's when they are at risk, and I think that's what we've learned through this process this year, isn't it? Because a lot of the work that you're doing is around prevention, around sort of just picking up a little bit of what Leslie was saying, is around that sort of almost social prescribing element as well. So it's without those things, and this is what we also sought when we first challenged the cut, was or the savings requirement, was what is lost. You know, how does this then impact on our statutory provision if we, you know, take that full cut?
Can I just come back on that? Because one of my statutory responsibilities as the Director of Health and Social Services is a break-even budget. It's written in statute, and I do have to do that as part of my responsibility, and that fits into that discussion we've had at the very start and we've come back to.
Hence why I just think it would be really useful for us to have a sort of baseline of what everything looks like, and then, you know, what we're talking about then makes a bit more coherent sense to a whole group of people that sometimes come into this committee that don't know those things. I guess my other question thinking about your statutory duty, I mean, one of the things you list in this paper is about mental health. And my question is, what does early intervention look like? So we've heard about the statutory duty and how you're all working together, yet, you know, what does early intervention in mental health look like for the average person?
So that's something Bathmind does all the time, and it's very much about having those early conversations, being available and accessible to people, having phone and in-person visits, and then developing a safety plan and developing a set of services, which is often social prescribing services, so that we can give people strategies to stay well in the community, whether it's coming into their own home, whether it's supporting them into other groups as well, and just working with them to do some of those very simple daily living skills that you and I would see as standard and normal. For some people, they're really, really difficult. And so it's about some of those very early practical processes, and then we'll take it to the next stage to make sure that people then can engage and connect in their community, because that's another problem for a lot of people, they disengage. And so that's the kind of work that we do before we go into the crisis sector or crisis mode.
Thank you. And just picking up on the point you made before around the budget, so I think possibly at the next meeting of this panel we will expect to see something more around what is proposed for those savings in the budget, and I think it would be very helpful for us to see how the savings target has been split between, so it's still being asked for, isn't it, the 802,000, but it's going to be split between 2025 and 2026, is that right, or is it all going to be taken in 2025?
What I would say is that we were expect to make 400k this year, which is 24-25. We haven't done that, and as I said before, I had a one-off grant that came from the Department of Health and Social Care, and that helped to balance the budget. That means it's 802 next year we've got to find, and that's what we're trying to work through now at the moment, because that's been the agreement in the medium-term financial plan, that by 25-26 we'll have found the overall 800, and that's what we're working through at the moment. So when I talk to you about £3 million for the sector, it's minus the 800, and that's what we've got to try and work through and find a way forward. That hasn't changed.
But you're working with the third sector on how that then is found, and you said, I think, that the 400 that you'd allocated from additional funds, that's one-off, so that's not to be carried forward for next year. So we're not looking at 1,200. yeah, 1,200,000.
To be fair, we're trying to be creative in our thinking about how we find that. That's the work we're doing right now.
We look forward to hearing more about that then. And I think my Vice Chair mentioned Julian House. Is that specific question being looked at through at the housing scrutiny panel?
Do you want it? I mean, Julian House have got a specific issue that the lease on their current building is coming to an end. They've been given notice. So they are working with the council. They're doing a lot of work to look at alternative provision for that, and that's something they're working with our colleagues in housing on. But obviously there's uncertainty about it at the moment. But I think that's looked at the climate emergency scrutiny panel, not this one.
Yes, absolutely, yes. When I said housing, I was referring to the climate emergency panel, yes, which covers housing and transport and a range of other issues too. Leslie.
Yes, it's recently been announced by the government they're going to put another £3.5 million into homelessness, although from my reading of it so far it seems to be mostly around veterans. But having said that, have you any idea how that might help out with a service like the one that Julian House provides, especially as it's got to move?
I can't comment on that. We can take it away, but as far as I know, it's going to the climate emergency scrutiny. That sort of discussion, it probably doesn't come through here. Just checking. I'm looking at Kerry for further advice.
Just so you're aware, Leslie, the climate emergency scrutiny panel will be receiving the housing plan in January. And like this meeting, it's a public meeting, so you can attend or watch it online if you wish. Right, I think we may have finished with that item. I'm now going to, I'm changing the order just fractionally, and I'm going to ask Laura to speak on the Integrated Care Board's update. I think you're aware of the sort of tenor of our questions and the sort of the what our main concerns are. So I would hope when you sort of address us that you'll be able to bring in those concerns. And just for the panel's benefit, I spoke to Laura, and it is highly probable that we will ask for an additional meeting so we can explore some of these concerns in greater depth. Anyway, so over to Laura.
Yeah, thank you very much, Chair. And just to say, everybody, I would like to welcome Caroline Holmes, who's also with me from the Integrated Care Board. Caroline is our new Director of Place in Wiltshire and is also leading on the Community Services portfolio, and we've been working very closely together, as you would imagine, on the Integrated Community-Based Care Programme. So we thought it would be helpful if Caroline were along with me today, and we're both very happy, just to clarify, to have another session, another follow-up session, as we see fit, or indeed if there are further updates that need to come to this panel. But just so that I navigate us to the report that you've got in your pack, at the moment there are 4 key areas in that report. One is the ICBC outcome, and what we've done in the report is set out the headlines on the key aspects of the services that will be in that new contract and the benefits that we can expect to see. The other 3 items in the report are around the group model and the appointment of a joint chief executive across our 3 acutes, and that's the Cara Charles-Barks, who is obviously the local chief executive of RUH, and we also have an update on our key worker programme, part of our learning disability and autism programme, and also for your information and to note the engagement on the 10-year plan. But as the Chair has indicated, we understand from the number of questions raised before the meeting that there are more queries and concerns on the Integrated Community-Based Care Programme. So, Chair, if it's okay with you, I was going to suggest that I would focus on that element of the report. And I think it's fair to say, as we've said, we'll answer as much as we can today, and, of course, a follow-up session if helpful. We are at this stage able to say more than perhaps we have been able to in other stages of the process, so I hope that will be helpful. And as we understand it, Chair, there are a number of key areas or themes that I think appear to be reoccurring, so I just thought it might be helpful if I set out some headline points around those key themes, and then of course very happy to answer any other follow-up points today. So those four themes, I think, being something around the engagement, around the process and the process itself, how patients and the public have been involved and or will be moving forward, the nature of a private provider in this space, and then the role of the local authority and indeed this scrutiny panel moving forward and the involvement. So if I take each of those in turn, if I may. So starting with the engagement around the process and the process itself, I thought helpful just to set out that the ICB, as we all know, had a legal duty to proceed to procurement because our existing contracts were ending and there was no scope to further extend. So in that context, this would not be subject to consultation because it's not optional. We were legally bound to go out to procurement. Now, I think as we also might recognise in this panel, private companies are entitled to bid for contracts, and it would be beyond the remit of the ICB and not legal for us to limit who could be part of that process. But I'll say a bit more about the process in a bit. What we did do was set out an expectation of partnership working, in particular with our local VCSE providers, but that we were very clearly looking for a lead community partner working in partnership. So they were the parameters that were available to us and what we had set out. So therefore, on this aspect, scrutiny panel, there was no opportunity for genuine or meaningful consultation around the procurement itself, i.e. who would provide the services. So, as you would expect, the procurement that we undertook was carried out in line with the requirements, and in this instance we followed the PCR regulations. So we followed those processes robustly. To note, they are set nationally, and we obviously need to abide by the outcome, therefore. When you followed the process of that procurement, one needs to accept the outcome of that procurement process. So I just thought it was helpful for us to recognise that landscape that we're working within. So I was going to move on then to the involvement of public and patients. And as we know, we were looking at a different approach, a transformational approach with our integrated community-based care programme. So we had approached this from the perspective of having transformation priorities and that we were looking for outcomes-based commissioning. So the ICB does have a responsibility to consult on service redesign, but the detail of that potential service redesign obviously could not have been known at the outset of this process. And it would be in response to the transformation priorities that the bidders came forward with their bid that we would then know that. So any consultation will be led by the provider and hence could not be outlined ahead of the conclusion of the procurement process. So all this to say that under this particular procurement, as I've said, the provider does have the responsibility to engage service users on its proposal, but crucially it's our responsibility as well as a lead provider lead commissioner to stand shoulder to shoulder with them when they do that. So from an ICB perspective, we've engaged on our priorities, which is in line with our core responsibilities. So what I mean by that, just to set that out, you will remember that we have engaged on our care model, and the care model formed the basis of what was in the commissioning intentions. We also have an ICP strategy with priorities within it, transformation priorities within it, and again, they informed those commissioning intentions. The commissioning intentions themselves were also informed, where appropriate, by those with lived voice. So if I give you an example of that, particularly in learning disabilities and autism, we made sure that we had some people with lived experience or lived voice that inputted there. And we held market engagement events. So in total, these reached around 255 people or 69 providers. And then finally, in the evaluation, we had service users and people with lived voice as well. So I guess what I'm saying there is that at each stage of the process where it were available to us within those procurement parameters, we looked to how it would be appropriate to engage people at the relevant stages. Moving forward and looking ahead is the time when we are now able to engage with service users, with the lead provider, to actually actively engage on those opportunities for their involvement. So that could include service users, but also communities more broadly, and indeed yourselves as a scrutiny panel. And we would very much welcome your views, and we want to work with you to hear your views on how we best do that with our communities as well. So just a final couple of points, if I may, Chair. One around the nature of private providers in this space, and I know that we've had a lot of queries around this. I've already said about the parameters and the legal requirements for procurement. And clearly it's not in the gift to exclude or favour any one type of provider over another, as we know, but we must follow a robust process. So by way of providing some assurance, I just wanted to set out in very headline terms, and this might be something that we can give more detail on at another stage. We had 4 key stages of the procurement process, the first being a selection questionnaire. So that's the point at which we are looking at the appropriateness and suitability of those people that have expressed an interest and come forward. We then had an invitation to tender, ITN1, that went out for bidders to respond to. And then following that, we had dialogue sessions where we were able, along with local authority colleagues, to probe and test the bidders' thinking and their proposals at that stage. That's quite a new approach and a new way of doing it, and is available to us under those procurement regulations. When we were confident that we could have at least one successful bidder, that we had somebody who were able to respond to the requirements that we had set out, we were then able to go to invitation to tender 2, and that is when we put our final procurement process out and had the responses back. And as I say, when you followed that robust process, you then accept the outcome of that process. So we had evaluation. There were 36 evaluators in total that evaluated those bids, and noting that HCRG, who were the successful bidder, had a very strong bid. And of course, as we know, they currently deliver outstanding and good services, not just in our local patch here in Baines, but also across BSW. 97% of their services are good or outstanding. So, looking ahead, HCRG themselves are very keen to work with the local authority colleagues and partners, including DCSE. They have attended the recent Health and Wellbeing Board, and I understand this panel get those papers, so hopefully would have had the opportunity to look at those. And they are very keen, obviously, to work with us moving forward to think about how we can shape the nature of engagement as we continue. So, Chair, I think I'll pause there. I recognise there may be many other queries as well, but I thought it might just be helpful to set out just a few of the themes that I think have been recurring, but happy to take any further points.
Thank you, Laura. And sort of slightly preempting what the panel might decide, if we did choose to have that additional meeting, I think we would like to invite HCRG to also attend. I don't think that would be out of order. Thank you. I just also wanted to ask about the market event. So, could you just clarify, because I know part of your remit, part of your guidance is around public engagement. Would you say that those market events are part of that public engagement? Because I would imagine that was more geared towards commercial operators, or otherwise, how is the public and resident patients, you know, how are they part of those early stages?
Yeah, so as I was setting out, there wouldn't have been an appropriate stage to engage patients and public at that stage. You're right, the market engagement was for those commercial providers. Where appropriate, we also had service users and live voice that fed into the commissioning intentions as well. But that wouldn't have been a formal public consultation exercise, because at that moment there was nothing that we would have been able to engage on specifically from a public consultation process from the procurement perspective. Did you want to come in, Caroline, to add on that?
Yeah, just to say that what informed the market engagement events was also some of the earlier work that we'd done on the BSW health and care model, and that had had extensive public engagement. And out of that model, we developed a set of key changes, really. So the development of things like neighbourhood teams, for example, advice and guidance, more specialist advice and guidance coming into local communities, and then thinking about some of those wider aspects of how we support communities and provide more specialist services. So those themes we'd developed with the public, and we took those forward into the market engagement events.
Thank you. I think whilst I think about your answers, I'll open up questions to the panel. Liz.
Do you really think, I'd like to challenge you on that, do you really think that you're actually finding out what the communities wanted for their public health, what the public health needs were? Because that is part of scrutiny, of health scrutiny, isn't it? Making sure that you meet the needs of people before going out to this contract. And I know what you've just said to our chair, and I'm not sure I'm totally convinced that you went about this with the needs of our communities here in Baines and Swindon and Wiltshire in mind when you went out for this market situation, this procurement, because it sounds to me like you want to go out there and get a provider. I'm not sure what the basis was for actually getting this provider. I mean, this will lead to other questions, I'm sure. We were all very concerned about HCRG, to be honest. It was Alison Vaughan who told us that HCRG services were taken back in-house. You know, that raises quite a few concerns for me. And, you know, without getting into litigation or anything, some companies and groups are very good at procurement and at the procurement process. So that's my first question. Do you really think you've actually met the needs of what our needs are in our communities, in our health communities for healthcare?
Yeah, I think our response to that as an ICB is absolutely. The entire process was designed thinking about our communities, our population health management. That is our statutory responsibility and what we're here for, really, and I'm sure that we're all working together to achieve that. As Caroline says, in our strategy and in our care model, that is where we understood what the needs were, broadly, at a high level. We then used that information to test with the market what would be potentially possible, what ideas would they have as a group of providers working day-to-day with service users and delivering on the ground. And then that informed our commissioning intentions that we put out there. And as I say, we did test our providers to quite a rigorous and robust process, a 4-stage process, including dialogue. And when they responded to us, clearly we were then able to evaluate that with appropriate representation at that time. And crucially, there is still the opportunity now, and indeed this is built into the programme, to work with that provider to then start to shape with service users what those services will look like. So yeah, absolutely, it is with our clear intent that we are meeting the needs of our population. Sorry, Caroline, did you want to come in?
Yeah, I was just going to add as well, one of the requirements of the provider going forward is that they work using a population health management approach, which means that they need to understand to a great detail what the needs are of their local communities. And we're not talking at a Baines level or a Swindon level or a Wiltshire level. We're talking about neighbourhoods and working with GP practices and local communities. So it is a requirement on them that they do that work going forward, which will help then design those services and keep them relevant to local people going forward.
I wonder if the process ought to have perhaps those opening questions considered before we go into the tendering process? I wonder if that's something we might want to think about at our next meeting.
If it would help, the nature of the types of questions that we asked, what the bidder had to respond to, which I think will help provide some reassurance, we could set those out so you can see the nature of the bar that we set and what we needed them to respond to. We can certainly have a think about how we look at that information and do that in a way that we're able to within the regulation requirements. Yeah.
Thank you. And I'll come to Ruth and I'll come back, I think. Ruth.
Thank you. No, I'm just interested because, as I say, it's already been decided, so it's a bit late, really. But I'm just interested to know how many bids were there and who were they from, if you're allowed to tell us that, or at least how many, even if you can't give us more detail. But that would be interesting to know. And yeah.
It might be that you can't name all the names, or maybe just the number.
Yeah, what I can say in broad terms is that we had more than one, and I can also say that we had a different range of providers. So obviously we had HCRG and there were other consortium that came forward.
It might be maybe we could explore that again in our meeting. Maybe we'll have like a private session within that too.
I was just going to say, perhaps we will go back and just check what level of detail we can provide to give you as much as is appropriate. So we'll go back and check.
Thank you, Caroline. Paul and then Leslie.
Thank you very much. Before you awarded the contract to HCRG, did you approach any of the other places where they currently go on contracts to get feedback, real feedback, as opposed to the feedback they put in their well-produced reports about how people felt about the services? Because the only feedback I've got from a person who works with this person is not positive. So 100% of my feedback is negative, which doesn't meet any of yours, but that wasn't a representative sample because there was only one person. So my question is, did you contact these other places where they're currently working to get real feedback from real operations?
Well, yeah, do you want to come in first and then I'll come?
I was just going to say we are aware of other areas where HCRG currently deliver services, and also we are obviously aware of their ratings currently within Baines and Wiltshire as well, so wider than just Baines. Yeah, thank you.
You didn't answer my question at all. Of course we are aware. There's a graph here with lots of little heart shapes on it showing all the places they work. My question was, did you approach any of them to get feedback from the users in those areas?
So not for this procurement. It wouldn't have been appropriate. When we look at the selection questionnaire, it's appropriate to consider at that stage suitability and past performance, but it is not appropriate to be drawing that, if I can put it, anecdotal evidence into the evaluation, because the evaluation, in order for it to be even-handed, you need to be looking at exactly what you're presented with. So not as part of this procurement. That would not have been a stage of the procurement, no.
I'm afraid that answer doesn't cut the mustard. If you've got a company, if we're awarding a contract of this size, of this magnitude and this importance, due diligence surely requires you to look at how the people that are bidding for you are actually delivering this service on the ground in real situations, as opposed to just well-produced tender documents. So I think for future contracts, you need to put in there very clearly that you will be following up with any applicant their current working around the country. I'm afraid I'm not very happy with that answer.
Can I just say that I think that might be a point that we might explore more within our next meeting, about what is desirable and what is perhaps legally possible as well.
Yeah, and I'm happy to do that. As I say, we can set out the due diligence and the nature of that selection questionnaire that I think covers everything that we could ask legally. That would have been the stage of the process that we would have done that. So yeah, well, let's set that out a bit more for you and see if that answers.
We'd like a direct question. Is it legal to ask about how other places where their service is being provided, how those users feel about it? What is illegal about a question like that?
Can I answer if you wish to, Laura?
Yes, we will take that away. All I can say to you is that clearly we had regulations that we had to follow, and we could only take into account the questions that we had asked them to respond to in the evaluation. But we note the concern that you have, and we'll take that away.
In that case, can we have the questions before any contract is ordered? Can we look at those in future before the process, not after the process and a done deal?
It's one of the points that I've made before, so yes. So we'll consider this. I think we've all noted the strong feeling. David. I apologise, David. It's Leslie, then David.
Thank you. And I think I would echo the feeling that Councillor Crossley is expressing across the hall there. So bearing in mind what you've just said about this contract, I asked a question getting on 6 months ago about physiotherapy, and we still haven't got the figures on how many people on the waiting list, how often are being seen. So what questions were asked as part of this procurement process around the quality of what's to be delivered? And in HCRG already providing a service in Bath and North East Somerset, what's the quality of it being provided now? And if you look at this report, it talks about transforming the way people access care on the basis that it should be reducing the pressure on GP practices. So far, we're not seeing much of that in relation to GP practices from anecdotal evidence I'm hearing from residents. So how is this going to improve access to the care, and what is the quality of that care going to be? And the other side of this is, if you look up HCRG, you'll see their last profits, this is not last year's, I think it's the years before, was £40 million. That's nearly as much as the amount we're short of in Baines. Their director was paid £621,000 plus a bit more. Won't worry about the pennies. So we're all obviously in the wrong job. But it's a bit of a concern if money is being pulled out of our public purse and being spent in the private sector. So what real benefits are we going to see back into our community from this contract? Thank you.
There are a number of points in there, so I'll take them in turn, if that's okay, and Caroline may wish to come in as well. In terms of the information on physiotherapy, we do have that, and I apologise that that has taken some time to get to you, so I will take that back and make sure that we circulate that for you. In terms of quality, we know that the CQC rating for HCRG is outstanding or good, and indeed the recent Baines CQC inspection follows that up, really. In terms of private company, I think as we've set out, clearly we have to be even-handed with providers that come forward. What I would note is that the nature of this contract requires transformation. The model works by requiring the transformation to be met and any release of funding to be reinvested into community services. So that's a requirement in the contract. Something that is not a requirement, but what HCRG have chosen to do, is to provide upfront investment, particularly during the mobilisation stage, and to ensure the safe transfer of services almost immediately, particularly in digital, and that is in the millions of pounds. I don't think I'm able to clarify exactly how much. So they have made quite a significant contribution, I would say, and significant upfront investment in order to deliver their model. Their model is a stepped care model, And I think some of you that were at the Health and Wellbeing Board would have heard about that. The nature of that model seeks to help with all of the things that you have just raised, Councillor, regarding access and how we might be able to relieve pressure not only on our primary care but around other parts of our system. So that role that I was describing about being a lead system partner. I didn't capture any other points, but Caroline, was there anything you wanted to add?
Yeah, the only bit to add, I suppose, is just in terms of some assurance around how we measure quality going forward. So our Chief Nursing Officer, Jill May, leads a team that oversees the quality of all of our provider organisations across BSW. That team specifically worked with us to agree a set of quality measures that we will use to assess the quality of those services being delivered going forward. And that also includes patient feedback as part of that. And we can certainly provide more information on that if it would be helpful.
Thank you. And as I've spoken about, I think it might be useful to have Jill come to our meeting as well to get that input from, you know, the patient's perspective as well. Leslie.
Can I just say that would be really helpful to have that information, to see what it is. It would be really good to look at the quality of the service, and also I don't think you really answered the question about how it's going to change access, and I'd certainly like to see that improving. With regard to the physiotherapy figures, I don't know why it's taken nearly 6 months to get them, so when can we have them? We did ask at the last meeting for some figures from the, sorry, I can't remember the name, on the virtual head, and she has provided that, and that's been provided in between. So when can we get those figures as well? Thank you.
I think, as I said, we have that information, so we can provide that. I think we haven't had a slot on the agenda to bring that back, but I think we can obviously do that between meetings, and we will provide that.
Thank you very much, Laura and Caroline. David and then Joanna. Caroline, do you want to turn your microphone off?
Thank you, Chair. David Hurling, Councillor for the Chew Valley Ward. Thank you for coming. Could you just tell me a little bit more about what is outcomes-based commissioning?
Can't turn it on, can't turn it off, so not doing very well this morning. So yes, outcomes-based commissioning is a different way of managing contracts going forward. So instead of managing at a very micro level, so individual service by service, we look at the needs of the population as a whole. And how we've developed the outcomes framework is when you're looking at services across a whole patch, if you have over 100 specifications, which we did have, it's very difficult to be transformative and to have flexibility about how you want to provide services going forward. So we've redesigned that into 3 core specifications. Those have a set of requirements within them, or must-dos, as we've called them, and those flow through into a set of outcomes. So those outcomes, for example, might be about somebody's experience, so for example, how quickly they are able to return home from hospital, and also how long they are able to live at home in the community. And the way we've managed the framework is that we then are able to attach what we call performance indicators to those outcomes, so that we can test underneath to see whether those outcomes are being delivered. But at a population level, we've used the outcomes within the integrated care strategy as well. So that's around the prevention of ill health and, for example, supporting people to live longer, healthier lives and improve their health and well-being.
Thank you. I think for us then it would be really good, I mean, great to see something that's improving long-term populations, whatever, but that's 10 years down the track, population stuff. You know, you go on to the HCRG website and you look at their case studies and they're working towards an integrated autism and ADHD assessment pathway. But we know that ADHD assessment right now is chaos. So it would be really good if we could actually see, well, however you wish to give the information to us, things like what the outcomes framework is, what the outcomes expectations are, what the performance indicators are, the must-dos, actually. You know, if you like, the targets you've got to hit, the hidden weights, the whole shebang, actually, because even if we can do very little about it as a scrutiny panel, we can at least scrutinise and say, you know, well, what's happening now with autism assessment in Baines? Has it got worse since everyone's joined up? You know, and if I may quote from the Health and Wellbeing Board, when we're harmonising delivery across the ICB based on the population needs matrix, that kind of the potential there is to sort of level down rather than level up. So it would be good to see all that detail, and I know that's a lot of detail, and it's probably extremely painful for Laura to hit, because every time I come here I ask for more detail. Anyway, that's my question.
Not painful at all, and I think spot on, and I think that's the role of this panel moving forward. So absolutely, how's it look and feel, and what's changed, what's different? That would be something that this panel absolutely we would welcome, bringing that back to this panel. We do have information around those outcomes, the transformation priorities and the outcomes framework, and I think we're happy to share that in a future session. So absolutely. I think the only point that I would note is, as we heard at the Health and Wellbeing Board, HCRG have got a very strong commitment about levelling up, not levelling down. And I think they were recognising that clearly some of their models are based on the good work that they have in Baines. The ADHD is a really good one, for example. At the moment, that's a pilot that they've been doing, a waiting list initiative. And the difference between that initiative and the improvements that have been made and access has been quite significant. So, yeah, I think that's exactly the space we need to get into. I'm very happy to compile that information for the next session and indeed beyond.
Thank you, Laura, and thank you for the question, David. I think part of what I wanted also to clarify was what is the role of this panel in terms of that scrutiny of the health contract and of health that is provided outside of the council as well.
Yeah, so the role of this panel will be for us to be bringing back what that service delivery looks like, and that it is meeting those expectations and that outcomes framework, and indeed the joint commissioning intentions that we have together. So that very much is the role of this panel. And as we just talked at the top of the item, we would very much welcome views around how we work with HCRG to engage service users when we are at the appropriate stage of knowing what service redesign, if any, we need to engage directly on, and how we do that with service users, how we do it with people with lived voice, people from this panel, your communities, and anybody else that we think is appropriate, and how we might do that crucially as well. So I think they're the two main roles. Thank you, Chair.
Thank you, Laura. Joanna.
Thank you. It's really interesting to hear about how you want to work with us through scrutiny. And I guess my question to begin with is, I've been sitting in this room for nearly 4 years now and wondering sometimes, I've heard the ICB monthly basically give us an update. So I'm just trying to think, a bit like the piece of work we've just heard now about the community support contract updates. We've known that there's a problem. We knew that they needed more money, that there isn't enough money. You clearly knew that you had a legal duty to make sure you had a contract ready. But at no point was that brought to us, or any questions around that brought to us. So I'm just wondering, you know, some of the stuff that you bring us seems to be a bit like, it feels a bit like a tick box exercise, I guess, is what most of us in this committee are feeling right now. And clearly people outside of this committee have told us. So I'm just trying to work out what this whole monthly report is for the ICB, really.
Thank you, Councillor, for the feedback. I think I'm sorry to hear that. Obviously, it's not our intention to make you feel that it's a tick box. What we try to bring is relevant and timely information, either because we think that you should be aware of it, or because you have requested it, or because we think it's something that you should be involved with. I think, as I explained, in the nature of this process, it wouldn't have been appropriate to have been engaging throughout the process, because, as we know, we were under procurement regulations. We did bring reports to this scrutiny panel, if I can remind colleagues, when we knew that we needed to think about the direct award and the extension to maintain safe services. We indicated at that time that we were embarking on an integrated community-based care programme, that would be looking across BSW, and that would be safe services from 1st of April 2025. And indeed, at times, that was linked in with the community partners update that we've just had. There was also a timeline update that went to Cabinet, just to set out very broad timelines for this process. But as the lead commissioners, the appropriate governance to take all of those updates through has been the Integrated Care Board and the governance that supports that. And I can see that it is unfortunate that how it feels, and I absolutely accept this, is that because we've been in a procurement process for a number of months, what you really wanted was to be having timely updates on that procurement process. And I hope you can understand that it's never my intention not to be forthcoming with information. It was because I couldn't at that moment in time. So I think that's where I am on that particular item. But of course, in terms of other items, if we think that we need to change the report, I'm always very happy to receive that feedback and think about, if it's not working for panel members, let's think about how we do that differently. Very, very open to that.
And let's pick that up then when we next...
well, I would say it's not working for panel members. I'm not sure now, whenever we get a report, what the ICB is actually asking us for, or what it's telling us, or what the direction of travel is. I'm a bit confused about how they're managing this, and in fact managing huge amounts of public money.
And I think that's part of the question that we also are asking about what is our role with this, because if as far as I'm aware, I think this is the only panel that looks at the ICB report. There's no other scrutiny body, is there?
The ICB has its own oversight and scrutiny and quality committee, but yes, in terms of local government governance, this is the only panel, so that is correct.
Thank you, Laura. Do I have any other questions on this item?
I do have one more question on the detail of the ICB report. What is an inappropriately located building?
So this is in relation to the Integrated Community-Based Care Programme, likely benefits to see. And we have worked together with HCRD. I can see how the wording might not be helpful, but essentially what it means is that there is a commitment to look at making sure we recognise that there are some areas of a state that are either in disrepair or not fit for purpose or inappropriately located. So there is a commitment to make sure that we are looking at providing services where people can access them, whether that is health on the high street or looking at our children and family hubs, for example, in a more creative way. So that's what is meant by that terminology, but I can see that when you read that cold, it's not helpful terminology, so we can, of course, take that back as well.
I would also challenge that by, I mean, so far the decisions you've made have not included us or encouraged us to think that we have been included, and therefore that makes me wonder that you'll make decisions about buildings that actually are really important to people, but you will have done a tick box exercise and then suddenly they'll disappear and people will go, oh, and then we'll just say, oh, well, it was in a report that says they were inappropriately located buildings, therefore. So there just needs to be a bit more work around how you work with groups of people to make sure that that is actually what that is. Thank you.
See, Laura's nodding there. Leslie.
Yes, can I ask around the neurodivergence? It talks about both of these continue to progress well. That's the mental health unit being built in Bristol and the partnership in neurodiversity in schools, the PINS. Can we have a bit more detail on the progress of that? I don't really get much from progressing well.
Leslie, can you turn your microphone off, Leslie?
Yeah, so we can bring back another update on the new unit. That's no problem. Progressing well means that it's progressing to timeline. So planning has been secured and we are on site. There was a groundbreaking ceremony a few months back that we went to and was included in one of the update reports to this panel. So it's just to keep it front and centre of our minds, I guess, that is an integral part of that pathway and that is working to timeline. We can certainly bring you an update on the new unit and indeed anything else around LDA if that would be helpful. I would note as well with the key worker service, it does feel a bit of a shame that we might not have had a chance to discuss that today. So if it's helpful, perhaps if we bring it back, we could encompass it into a broader item, if that would suit the panel's needs.
Is that satisfactory, Leslie? Yes? I believe my Vice Chair has a question, another question.
We're led to believe HCRG are going to be operating a brand new model for community health, that they're going to be revving up rather than revving down. But to what extent will our communities be involved in the development of specifications of this healthcare?
So I think as we've described, what we're looking to do is work with HCRG to think about what the service design will be and work with service users. They won't be specific service specifications as Caroline has outlined and as I outlined before. We've got broad commissioning intentions around our adults, our children's services, and indeed LDA is part of that. So we very much want to work directly with service users and those with lived voice, and we have done to date, and we had some that actually helped us evaluate the proposals as well. So we had people with lived voice and service users who were part of that 36 evaluation panel. We had several that were lived voice or service users on there. So yeah, we want to continue that moving forward.
Thank you. Is there any other questions or comments? Otherwise, we will move on to the next item. Thank you, Laura, and thank you for your commitment for a further session on this. I think you'll get a sense of the various themes that we'll want to explore in greater detail. As at the end of the day, this service has to be providing better for our residents, particularly in Bath and North East Somerset, but obviously, I would say, in Wiltshire as well, and possibly Swindon. Okay, right, thank you. So we now move on to the next item, which, as I indicated before, is a slight change in the order. So I'm moving to Alison to just give us anything further you want to add in terms of your update.
Thank you. Yes, you've got my update report. Just before and I'm not going to go into detail on that because you've all had a chance to read it, but I'll highlight a few things. Just before I go into that, I just wanted to make a comment in relation to the community services procurement, which reflects the administration's view on this. And just to say, the Liberal Democrat administration of this council believes that NHS core services are better provided by NHS providers. and that view was compounded when in 2021 Virgin Care was sold to a private equity company without the knowledge of local commissioners. That action and the associated loss of trust led to our decision not to extend the HCRG Care Group contract for health and care, and to undertake a detailed review of the options available to us. The outcome of that review was that we as a council took the decision to transfer local adult social care services back within Bath and North East Somerset Council in April this year. Following this change, we had hoped that our directly managed social care services would be working with NHS partners in future, but the outcome of the recent competitive tender process for community health services was, as you know, that the contract was awarded to the HCRG Care Group, which is not an NHS organisation and continues to be owned by a private equity company. You'll understand that this was disappointing, but we fully accept that it was the outcome of a robust procurement process that followed national guidance. We also recognise that you cannot predetermine the outcome of such a procurement process, but you can be assured that the preferred bidder will be a competent organisation, as Laura has set out, about the tests that will help them know that, and that it will have produced the bid that scored most highly against the service specification. We will be expecting to work with NHS and local authority partners across Bath and North East Somerset, Swindon and Wiltshire, and with colleagues in HCRG Care Group for the duration of this contract to ensure that the new community health contract delivers accessible, effective and high quality services for our residents. And I think given that where we are now, that is what we really need to aim to work towards. So that's a statement. Then just moving on to the rest of the report, there are a few bits of good news in here which I'll highlight. One is that we have now got planning permission for the Englishcombe Lane development, which means that we will be moving forward to develop specialist accommodation for people with learning disabilities and autism who've got very complex needs. And that's going to be really positive in terms of our being able to meet those needs locally within Bath and North East Somerset rather than sending people out of area. And it should also help our budget position, because at the moment a lot of those contracts are very costly for such placements. Another good bit of news is that in the public health section, the Royal Victoria Park leisure facilities, we've got a new contract for those, and that will entail quite a lot of investment in the facilities there. There's already been a lot of investment in the cafe, and I have to say it's looking really, really good. So that's very positive. There's also a few challenges in here. One is that as always, we are working with budget challenges, but we have got a plan this year to break even, and obviously we will be looking very carefully at the planning for next year's budget. But it is a really difficult environment we're working in. Demand is going up, costs are going up, and the resources we have to meet need do not always match that. And as Suzanne has said, one of her duties as the Director of Adult Social Care is to produce a break-even budget. So, it's a constant challenge that we work with. Another challenge that I wanted to mention in relation to public health is the work that's been done on a synthetic opioids preparedness plan. This is a growing threat to public health, and a lot of work's been done in that area, which is really positive. And I'll just finish with one more good news thing, which is the work that was done on Black History Month, which is a really positive piece of work done within adult social care and with our third sector providers. So, really positive. So I'm happy to take any comments or questions now. Thanks.
Thank you, Alison. Any questions? Liz is first.
Definitely taking Kevin's place here, because he's usually first, but also he's put forward a question, and he's asking about drugs and alcohol that you just mentioned, and he said, how is the information being delivered to young people? He also asks about the food access toolkit. In what ways is this making an impact? And I have another question of my own, which I'll ask in more with the Chair's permission.
Thank you, Councillor. If I start by the food access toolkit, it's a really interesting piece of work that's been developed by Bath University as a result of some engagement, some research that they have done, 3 pieces of research that they've done with our local population. And it's a board game, so it's a very interactive way through a board game and using case studies that are printed out, sort of giving the lives of different people who experience food insecurity. And it's a good way of enabling conversation and discussion amongst local people and amongst local organisations about how best people such as people in the game could be supported. So at the moment it's just being rolled out, so we don't have any information yet on the impact of it. I can certainly find out how it's being used in the couple of areas where it has been discussed. In relation to young people, drugs and alcohol, it's a difficult balance. So we've got Project 28, which is commissioned to deliver our drug and alcohol services, and they do work with schools. In terms of raising awareness about synthetic opioids, there is some limited awareness raising that is happening around that. It's always a difficult balance between awareness raising around something that is dangerous amongst young people who aren't at all interested in drugs, because of the potential unintended consequence that it could attract interest for young people for whom it wouldn't otherwise, and at the same time making sure that people who are at risk of using synthetic opioids or coming across them through their drug use, at the same time making sure absolutely they are aware. So a lot of that education and awareness raising is happening through our drug and alcohol services and through our police services at the moment. But Project 28 are fully involved. Thank you.
Permission, Chair, if I can ask a question myself. There's quite a bit of information about preparedness for winter, and I wondered about it's mainly about social care and social workers, etc. But I just wondered about warm places for our residents, mainly our elderly residents. And I think if we remember back, was it 2022, we passed a motion in Council to say that we would be looking at warm places. Now, we produced a list. I was wondering, are we going to have a look again at this? I mean, it's been very mild at the moment, but it won't always be this mild. So I just wondered, should we start looking at being prepared for the provision of warm spaces for residents, especially elderly residents?
So it's not, I'm sure Vicky would want to come in as well. We relook at the list every year, and obviously we want to continue to offer these spaces, but actually the third sector in particular are offering quite a lot around this, and we'll continue to do that. We've no intention of stopping offering warm spaces. Yeah, it is very mild at the moment, but I can see that another month and it could be quite different.
Yeah, just to clarify that absolutely the third sector working really closely with the council on the spaces that we have access to, whether it's in our shelter accommodation, our spaces that we use, our own supported housing schemes, all sorts of areas that we have, community wellbeing hub, and we're making sure that we're bringing people into that space.
Would it be possible maybe at our next meeting that, I think it's Councillor Bourne's area, that we get feedback on this, we find out what's happening, because I think it's really important, especially if the third sector is involved as well, that we get, I think our chair was saying about getting a map up and ready so that residents are
There was a map where there was access to, sort of, where's a warm space near me. And I think last time it included church provision as well, so I don't know if that's something that naturally would come under what you're doing, Kate, as well.
Around winter planning, it went through the Health and Wellbeing Board.
It did.
Last month. So there's lots of information about winter planning across the council and across the health services. There was a whole big presentation on winter planning which formed part of this.
But we can map it for you.
Thank you, Kate. Thank you, Liz, for that great question. Thank you, Becky, who, if anybody is not aware, Becky Reynolds is our Director of Public Health. Joanna.
Yeah, thank you. Thank you for the Cabinet update. My question is on the drugs and alcohol. I'm sorry, Becky Reynolds, I am really challenged by what you've just said about young people either not being interested and therefore making sure that you appropriately put information in the right places. We clearly know that the synthetic drug industry is causing havoc, and a huge number of young people do not even understand what the problem is and how it could affect their lives, and in some cases kill them. The fact that we need to alert all young people to this real danger is imperative, and I actually think that there needs to be a proper piece of work around this for all young people. I clearly know, sitting at my dinner table with young people, they are scared and they are aware of the issues, even if they're not interested in taking those drugs. So how do we ensure that we are delivering and keeping them safe?
Thank you. That's a really good point. I wonder if it would be helpful, what all local authorities have just had to do, or what all combating drugs unit partnerships have had to do in the last month, is to submit to the National Joint Combating Drugs Unit their plans on how they are preventing, monitoring use of, responding to situations of synthetic opioids. And we've very recently, just in the last month, our local partnership that's co-chaired by police and by public health, we've submitted our plans. So if it would be helpful, we can put that at a future agenda item. If colleagues, if Scrutiny panel would like more information on that, and we can have a bit more of a discussion, because it is a concerning issue, absolutely.
Joanna, can I just check? Are you talking specifically about synthetic opioids, or are you talking about sort of drugs and alcohol in general?
About drugs and alcohol, but the problem is that they are creating synthetic opioids that young people are taking, which is killing them, and that is our problem. And lots of young people don't know what they're taking is created by people, and that will probably have huge detrimental effects. And you know, it's like, I'm trying to think of an analogy, you know, that we make sure all young people learn how to cross the road safely, even if there aren't cars coming. So, you know, even if there's a car coming, they then know how to deal with it. They could be in all kinds of situations where drugs are put in put in front of them, that they don't recognise the dangers. And what we really need to do is make sure that there is proper work done across our local community, including HCRG, to ensure that that does not happen. And they know the dangers that are involved.
I think your suggestion, Becky, I think will be well received, to actually have that report, and perhaps it could be accompanied by a representative of the police, as well as they are the drivers of this. Thank you. Leslie, did I see your hand?
Yes, thank you. I just wanted to pick up a point that we raised last time, that we're getting information about lots of initiatives, but what we're not getting is the outcomes and what's happening, so we can scrutinise it. I used to work in drugs and alcohol with young people. You know, they don't have a problem, they open their mouth, they took it down, it ain't a problem. The problem is trying to get the issues over and those health messages, which is not easy. So we really welcome a report on the sorts of initiatives that we take in Bath and North East Somerset and the outcomes of them. I'd also like to ask about the food access toolkit. Again, it sounds like another innovation which sounds good. But when can we receive that report, the outcomes report, as Councillor Harden's asked for? Thank you.
Sorry, I'm not sure who's answering that question. It's, I think it's by you, Alison, but I think Becky's going to answer it.
So go on. This is the food access toolkit.
I'll allow Becky to answer it for you.
Was whispering to me briefly about something, so I missed it or some of it.
Okay, I think Becky was going to answer it anyway.
I think you were asking Councillor Mansell for a report sort of setting out the outcomes from the food access toolkit. So we can certainly bring a report in the future about how it has been used. At the moment, and it'll be a report on the numbers of partners engaged and the types of conversations and the types of outcomes from those conversations. As I say, it's very much a tool to enable facilitation in local parishes with local groups around actions that they might want to take around supporting local populations experiencing food insecurity. So we can certainly bring something at some point in the future. It's very new. It's only just been launched, which is why I thought the scrutiny panel might be interested in it. It's been heavily, the Fair Food Alliance has been very heavily involved in it as well. So we can certainly bring it at some point, probably in a year or so, when we've had a chance for it to be used.
So I guess this is linked to the work that I think the Climate Emergency Scrutiny Panel were doing around access to locally grown food as well.
It's all linked in the sense that we're aiming to have a food policy, a food strategy in the future, absolutely. So I suppose it's a strand of it. Addressing food insecurity is a strand of that broader policy.
Thank you, Becky. Do I have any other questions for the Cabinet Member? No? Okay. I know, Alison, you needed to go to another meeting, don't you? So thank you. Thank you for staying for this one. I was expecting Paul Scott, but Becky, are you being Paul Scott or is Paul Scott outside? Okay, lovely. So the next item on our agenda is going to be the implementation of the suicide prevention strategy. But I see people are seeing the opportunity to make a dash for the door.
I'm going to stay for this. Suzanne was saying it's okay if I go late to our next meeting. She would give apologies, so I'll stay for this bit.
That's very much appreciated. Thank you, Alison. Well, it's lovely to see you, Paul. I might ask you to introduce yourself. Did you need to set yourself up at all? Or?
Chair, you have Councillor Jackson's statement.
Thank you for the reminder. So, whilst Paul is setting himself up, perhaps, Councillor Jackson, you would like to make your statement.
Chair, you disappoint me. I thought you were going to say it was like the wedding in Cana of Galilee, that the best wine had been left until last. Seriously, I think this is an extremely important topic, and I welcome the fact that that it's on the agenda and you're bringing the issues forward. And thank you for permitting me to speak. Well, it's not mine. This is working all right, I take it.
You are working perfectly well. Carry on.
It's quite a few years ago now that I attended a wake at St Nicholas's Church, Radstock, for Jamie Hogg, a 20-year-old NEET who had taken his own life out of loneliness and depression. A grant had been found through our then in-house youth services for some art therapy for the bereaved young people, but a long-term solution was needed. I asked around the group, what can BANES do? The answer was unanimous. The youth clubs are doing great work for children, but we feel we are being abandoned when we turn 18. Some of them were alienated from their parents, some had poor skills, and all claimed that if they indulged in a little ketamine, which was then nothing like the problem it is now, it was out of boredom. Of course, for good or for evil, social media hardly existed then. So we found some money for a survey of youth homelessness in the Soma Valley. It came out in 2012 and established that, with mediation, most teenagers could be reintegrated in their family within a month. And Sam Plummer, now of Youth Connect South West, ran a programme on the health costs of ketamine consumption, which at least in that generation reduced its use. The senior Radstock GP told me that he thought about 70% of Radstock young people had clinical depression. So this that we managed to do was really only a drop in an ocean. Real change was needed then and now. It is also much more important to achieve early intervention, even at school. Reading the report, which is a good systematic approach to the problem, But suicide is not like life crime or growing food. Each case has its own individual consequences, and it has a myriad network effect, scarring families and communities for years. I am not really sure that there is in this survey that we're presented with today a grasp of recent changes and the challenge of social media abuse and bullying, not to mention the ease with which young people can gain information about methods of suicide. The new Minister for Education, Ms Phillipson, is changing the emphasis on education to children's well-being rather than a narrowly focused academic excellence defined by rigid criteria. Societal pressures probably weigh even more heavily than school ones. It is good to see both multi-agency cooperation and apparently much training highlighted in this report. But despite 16 years on the planning committee, I have never seen a planning application where suicide dangers are considered, contrary to the claims that are made here. And surely there are more suicides from people jumping under trains than on other forms of public transport, but the question of safety at stations is not addressed. There is no mention of the side effects of some prescription drugs, such as the well-known anti-high blood pressure prescription medication, which can produce suicidal thoughts. One factor are young people, whether at home or at school, or in youth clubs. They need stability and continuity. They need to know where they can get professional help if they need it, and not feel embarrassed by so doing. Labelling them won't help. This council making sure that such expertise and local knowledge is available is crucial. 15 years ago, the churches together, the police and Norton Radstock Town Council pulled together to help young people with a programme. Today, you cannot outsource your responsibilities. Charities do not have the funding to substitute, and residents are so busy making ends meet at a time of spiralling costs that they cannot contribute much or volunteer as often as they might like to. In 1975, a brilliant close university friend of mine moved on to a postgraduate course in Oxford and took her own life. She had a working class background and her family had not understood the problems that she faced. The Bishop of Burnley took her funeral, brief, perfunctory and without even mentioning her name. I and my friends organised a Thanksgiving at Birmingham University afterwards. I have never forgotten how distraught her family was. Suicides are much more than statistics, and whatever their age or background, there needs to be effective prevention now for all our residents. Thank you.
Thank you, Eleanor, for your statement, and thank you for turning the microphone off. Paul, would you like to introduce yourself? And then, I don't know, Alison, if you wanted to, if you had any comment before Paul spoke.
I can try. Can you hear me okay through there? Great, thank you. Hi, I'm Paul Scott. I'm Associate Director of Public Health working in Becky's team here in the Council. And I'm the Chair of the Baines, Swindon and Wiltshire Suicide Prevention Group, as well as the Baines Suicide Prevention Group. And thank you for your comments, Councillor. I'm happy to just reflect on one or two of them, if that's helpful. I don't necessarily disagree at all with anything you say, so make some really profound and important points. I would just emphasise, I suppose, that there is a lot of work with young people and local schools through all sorts of local organisations, either whether it's third sector organisations of different kinds, or whether it's in schools. And I feel like schools do have more of an emphasis, as you say, on well-being than perhaps was once the case. But resources are tight, aren't they? And teachers' time is tight and third sector is pressured, so there's a limit to what people can do. I'm sure we could always do more. In terms of, you just mentioned about trains, for example, and actually there has been good work. We have good relationships with British Transport Police and also with the Samaritans who've done training locally with station staff, and there have been kind of signage and campaigns previously, but there are always issues. It is a minority of deaths that happen locally on the train line, but one of the problems is they tend to happen in places where there isn't much surveillance at all. So even though you can do training with staff, for example in Bath Station, deaths tend to happen away from stations, down a line somewhere where it's just very difficult for the Transport Police or Network Rail or others. But we do work with them because it is a really important issue. And likewise with stigma, both in our mental health work and our drug and alcohol work and other things, lots of organisations really work hard to try and dismantle the kind of myths and the kind of exclusion around stigma. So again, it's a work in process, isn't it? And any particular moment you might not see it, but over time, I think attitudes have been better and people do feel more open and able to talk about things. So I feel like there's some, there is some of those things happening, and it does respond to some of those things. And I completely agree with you that although we sometimes take what might appear like a population approach, so it might look a little cold and distant because we're grouping people together, we totally recognise the very unique nature of all these deaths and the individual impacts it may have on families and friends. So I recognise that as well.
Thank you very much, Paul. And before we talk about the report, I just wondered if Alison had any comments that she wanted to add.
No, I just wanted really to also thank Eleanor for her statement, which, you know, was very powerful, and it's really important that those things are said and understood. And, you know, suicide is a really complex issue. And I think what this report does is it shows the breadth of the work that we do to try to minimise suicide locally. And, you know, I've got huge gratitude to all the services that are working on this agenda, because it is really, really important. It's good to see that our numbers have improved recently, but, you know, that doesn't necessarily mean that won't change again. So, you know, it's something that we really need to keep working at, and we need to keep looking at what are the causes and trying to tackle those, as well as making the changes to the sort of short-term safety things. It's actually about, a lot of it's about well-being and ensuring that people feel valued. And that's, you know, that's really important. It's something we all need to work on.
Thank you, Alison. I think very well made points as well. So, Paul, before we open up the floor to any questions, is there anything you wanted to stress in your report?
I suppose just maybe a sentence or so, just reminding some of the context of it. I mean, as you just mentioned, it's good that the numbers of deaths in Bath and North East Somerset has fallen consistently for the last 3 years running. We're below the national average, and the national average in England has gone up in the last year. It's the highest it's been for about 10 years, and it's particularly high in the north and the east of England. But it's good that in Bath and North East Somerset, it's gone down consistently for the last 3 years. So that at least is some, you know, that's what we would want to see, a decline in the number of deaths each year. A new national strategy came out last year, so that's why we're kind of refreshing and addressing our own to make sure we're looking at the most important groups or issues. And actually, as you said, online safety is, of course, a bigger emphasis than it was 10 years ago in the previous national strategy. We're trying to coordinate as much as we can with colleagues in Swindon and Wiltshire, and so that we've got, you know, we're trying to make the most of, we have relatively, you know, minimal resources that we can work on these things sometimes across big populations. So by working together, we hope to be more effective across all organisations. The action plan hopefully demonstrates lots of action and lots of work that's happened across all sorts of themes, and there are in there's actions identified about the work that's gone on to do with the rail network, for example, or work in schools, work at different ends of the spectrum. So I hope it just gives a real array. In a way, I know it's quite a lot to see, But with suicide prevention, there isn't 2 or 3 big projects you would do that would perhaps reduce the risk of suicide. It's more about so many different services in different ways, whether they're workplaces or schools or third sector or the NHS. So it's really important to see all those measures going on that can just reduce the risk if people have contact with people who may be at high risk. So hopefully it gives a flavour of that.
Thank you very much, Paul. So, Joanna.
Hi, thank you for the report. I see it's for noting. Could you explain 3.10 surveillance data to me, please?
So there's a national programme around what's called real-time surveillance, and that's different from that data that I just mentioned, and you can see the chart under 3.5, where you can see national data from the Office for National Statistics. That takes at least a year to come out. That's regular kind of data, and isn't always very helpful in terms of, it tells you what happened a year ago, but if we were having, for example, a number of deaths occurring on the rail network, I would want to know about that within days or weeks so that we can start to take action. And so it's called surveillance, which sounds a little bit Big Brother, but all it is a notification. So when a police officer, in that circumstance it would be a British Transport police officer, attends a scene, they have to complete something called a sudden death report. And now when they do that, it also notifies us that there's been a death that could have been from suicide. And so immediately, within a day or so, we'll know that there was a death. And we'll know very minimal circumstances, because we don't need to know more at that point. We just need to know what sort of, some rough details about the person, the location and the nature of the death. And that allows us to then do 2 things. One, be aware that, for example, has there been a second death at a rail site, or a second death amongst a young person or something like that. It also allows us to immediately organise a referral for the family and friends onto our bereavement support services. And there's good evidence around reducing the risk to families and friends if they can access bereavement support within that first 72 hours or so. So that's a service we commission, and it's run across, for us, across the Avon area by an organisation called Second Step. And before we had that kind of immediate contact from the police, we were not able to do that because we didn't know about those deaths. So that, what's called surveillance, just allows us to have a good picture so that if something happened, and you were concerned about something, we'd be able to know over the last month, have we had new notifications, where were they, and so on. So it's that kind of population level of surveillance. I hope that answers the question.
Useful to hear, thank you. And my other question, sort of at a sideline, is that we clearly know that social media is impacting lots of young people, or people generally. We also know that catfishing and that kind of behaviour is impacting young people and leading to suicide. Thinking then about your surveillance, there will be times when that information is just not known about why they've made that decision. And I guess I'm just trying to pull out something about, and I'm not sure how you would take that forward, but there's something there.
I agree, and it isn't something we're easily able to get any information from police colleagues, not least because I guess if there had been something probably implicated, it would be going through a coroner process, and so we don't know for a long time afterwards, and often even not then. So in a sense, it feels like the actions around that are the preventative ones, the work in schools on staying safe online and things like that, as opposed to us finding out about it after a death and sort of working through that process, which the police might, but may not be able to do. But yeah, so it's more like working in principle on online safety for all young people is the approach to that. And in fact, we were just talking about that in a meeting this morning on our preventative work.
Thank you, Paul. Leslie.
Yes, thank you for the report. It's not an easy area to work in, is it? Not in any way, shape or form. I'm really interested in the equality impact assessment. You've talked about risks of poor mental health amongst LGBT plus people, lesbian, gay, bisexual and trans. For a long time there was no information from that community because it wasn't being measured by the National Suicide Prevention Agency. It does now take anecdotal information. I wondered what you got in the impact assessment around that, and not only that, what about you know, we've got figures going down, which is fantastic, but what about those different communities? You've given us some at the bottom of page 40 around children and young people, middle-aged men, people who self-harmed. I've got no idea who that is. Is it women? Is it men? What about farmers? They're a high-risk group, farmers. And obviously we've got a part of our area that is rural as well. The other thing is the link between food insecurity and mental health. There's work being done, especially in Bourne in Bradford, where they've made that link from the data they've got, which I understand has been sharing. So have you got information on that? It'd be really good to know, you know, what we're doing that is making a change, because if that can be reproduced elsewhere, then I'm sure that people would be grateful for that. And again, it'd be good for you to come back and report on the action plan and the outcomes from that. It's good to see an extensive action plan. I don't see much about equalities in it, but, you know, maybe you can come back and tell us next time. Thank you.
Thank you. Yeah, thank you. That's a really helpful, detailed set of questions. I can just answer some of those briefly. You've mentioned some important groups. The work around the LGBT community comes from a review of national evidence, where there are higher rates or prevalence of poor mental health and self-harm amongst LGBT communities, as well as alcohol and drug use as on the whole. There's good evidence nationally about the highest rate in middle-aged men. That does appear to be a bit of a cohort, meaning that that same group who've got the highest rate had the highest rate about 5 or 10 years ago in a slightly younger group, so we might expect them to maintain that as they move into their 50s and 60s. It's a group of people born in around the 80s, 70s and 80s. Farmers you mentioned, and there's some other higher risk occupational groups as well, including teachers and nurses, particularly in different sexes. And so they are issues we take on board locally. They're issues being addressed nationally, thinking about what those risks are. Sometimes that's stresses of the job and isolation. Sometimes it's actually about access to the means. People have access to the means to do things as well. So it's trying to find the right way to intervene, both in terms of support and in terms of looking at how you can reduce access. In terms of coming back to talk about actions, very happy to bring back our refresh strategy. We've got a stakeholder event at the end of this month here at the Guildhall, and we have a wide variety of organisations coming to take part in that and comment on our action plan and help contribute to that. Colleagues from Bath Mine, for example, and others helping to organise that and make sure it's as relevant as possible locally, and includes hearing from people with lived experience locally to make it as relevant as possible. And when we've got our action plan ready, and we can perhaps make sure there's a sufficient amount around inequality and inequality, different groups with higher risk, very happy to come back and talk to that, which should be a more up-to-date plan, because this one is 5 years old now when we made that, so very happy to bring something back.
Thank you, Paul. And I'm just going to ask Kate if she wanted to add something.
Yes, thanks, Councillor. Just to pick up on a couple of your points, Councillor Vanderbilt, I think we are working really closely with the council, so that's the third sector and other organisations. So there's very much a kind of coordinated approach, and as a mental health provider, suicide and suicide prevention for us is absolutely the forefront of what we're doing and what we're trying to work with individuals to prevent. And the development of some integrated care records and shared data means that we can create a more preemptive, if you like, a preventative approach, because we have patterns of behaviour and areas and individuals who we are particularly concerned about. Picking up on some of those cohorts, individuals, we can work really closely with our NHS colleagues and with Council about some of those individuals that we're particularly concerned about, and we can develop a plan. So it's very much about preempting rather than closing that barn door after the horse has bolted, which obviously is always the last thing we want to be doing.
Thank you. Can I just come back on this event in the Guildhall? Is that going to be online as well? I'm just thinking, you know, it can be difficult to get into Bath. We've got young people that don't want to get on a bus these days, so following COVID. So will it be online as well, so it's more accessible, or will you do something out in North East Somerset?
It is a face-to-face meeting, and it's mostly organisations and representatives rather than individuals and young people themselves. I wonder if we could explore something about if there's a sense that it would be good to do something in North East Somerset, we could explore that. It's felt that representation is just harder.
Cool. Do you want to move, because you're the only one who's actually getting any sun?
Let's move sun to here. There we go. I hate to work out the sunshine. I haven't seen it for about 3 weeks.
Now we got some.
Right, any other questions, Liz?
Your suicide prevention strategy looks incredible. It's very thorough, lots of information and lots of measures of success. Now, I suppose, just to put in a little bit of challenge, I would have expected appendices at the end to say what you're measuring your success on. So, for example, integrated suicide prevention, you're saying promotion of annual campaigns such as Every Mind Matters. I'm sure you'll be doing that with Kate. But, you know, how many people went to that? And how can you measure the success that has arisen from things like this? So we probably needed a little bit more detail, because you've put the information there and we're taking you at your word. But it would be good to help us in our understanding of what actually has been successful. Which of your prevention strategies, your measurements of success, has been most successful, and maybe explaining to a certain extent why our suicide rate has gone down. But the other thing I wanted to ask, and is, once again, Kevin is raising his head. Kevin is somebody who attends this meeting and couldn't attend today, and asks lots of questions. So on his behalf, I'm asking one or two.
You also ask lots of questions.
Oh, should not. But it's about schools, and especially our multi-academy trusts. Because, I mean, he's wondering, how is support for mental health in schools coordinated? And you've said a lot of work is going on in schools, which is obviously a key area, isn't it, to get our young people early and look at suicide prevention strategies and look at mental health and well-being. But he wonders how support for mental health in schools is coordinated, and how are multi-academy trusts involved in this?
Thank you. So just in relation to the first point about kind of evaluation and the metrics, I think it's a really fair point, and I acknowledge that it would be great to have the time and to be able to put a bit more dedicated time into really tracking down some of those metrics throughout the strategy in terms of what was achieved from them, what can we be sure of, what can we measure. I think that's mostly just been with the capacity we've had, we've focused on the doing in the kind of sense that we feel they're evidence-based actions and we haven't put as much time into evaluating them. It would still be good to do, and there's nothing that stops us over this period while we're creating our new strategy to kind of see whether we can capture some of that in a more structured report in terms of what we've achieved before we move into the next one. So, I mean, I think it's a reasonable point. I acknowledge it, and it's just finding the time to do it.
Immediately on that, I mean, you're obviously doing it. You obviously have this information. Maybe it's just picking out the most telling bits of information that you know, the strategies that have been most successful would have been quite useful.
Yeah, sure. Happy to do that. I think, as you can see, there's probably 50 actions in there or something. It's what feels like an intuitively straightforward thing to do does start to mushroom before you know it. So, but I think it's we would like to do that and capture it in perhaps our next annual report or something. In relation to the schools, the work is the work goes from the public health perspective. Goes through the schools hub, and we provide a lot of resources and support around kind of whole school approach to mental health. And I know lots of other colleagues and organisations have closer links in terms of providing support with schools. I'm not so close to it, so I'll be completely honest. I'm not entirely sure how that's entirely coordinated through our either children and young people's kind of commissioning in the local authority or within the ICB and so on. I don't know if Kate or anyone else would have a better sense of that, but I'm less close to that, our children and young people's kind of mental health work in schools.
So we could also pick that up with the Cabinet members at our next meeting, which would normally have a focus on children's matters. Alison, sorry, were you shielding yourself from the sun? Or?
I was trying to stop being dazzled.
Okay. So thank you. Any more questions for Paul? In that case, I would just like to say thank you very much for your presentation, but I would also like, and answering our questions, you did say you would like to come back with the and I was just wondering when you thought that that would be an appropriate time to come back. I mean, we're looking at the spring or much later?
Yeah, I think so. I think we would, I mean, I could check in perhaps with Carrie and Mark and colleagues around the timing, but probably not before about March, realistically, to go through our kind of all the feedback we get from our workshop at the end of November, and then spend December, January putting that into a plan, but working with the partners to what people can commit to. So yeah, probably not before March, I would say, and I'm happy to coordinate on agendas if that's helpful.
Okay, well, we look forward to seeing you again. Right. In that case, now we move on, I think, to our last item, which is the panel work plan, and we've obviously got commitments of a number of items to come back at, so from the community contracts. Obviously, our next meeting will look at the contract award to HCRG. We also know that the suicide prevention work will come back in the probably around March time. Is there anything else that's come up during this meeting that you wanted to ensure was on our work plan, or anything else that has been missing that you want to see on our work plan for future? Becky.
Just the synthetic opioids, and I'll pick that up with Paul later.
Thank you, very good point. Anything else for anybody? Liz, are you about to say something?
I think that we have the community health service, the transport service to our hospital school. I'm just double checking that we haven't actually got it on our work plan.
Transport hospitals?
Sorry, transport to our hospital school, to the children who would attend our, I think it's called the
HERS.
HERS, yeah.
Is that something that would normally be within homeschool transport, or is that something slightly separate? I don't know. We'll make a note to make sure it comes forward. Chris, were you about to say something?
Music service.
We can. I think it's well over a year since we last spoke about the youth service.
And the other thing is that the next meeting is education.
Thank you, Chris. Any more suggestions for future agendas? Otherwise, I will bring this meeting. Oh, Ruth.
Have I missed it? I think, did we ask at some point to have a bit more information about home-educated children, home-educated?
Did, and I think that was expected to be at our next meeting.
Yeah, okay, so I don't see it.
But we will make sure it's, if it's not on there, we'll make sure that it is. Yes, thank you. Right. Will you be coming to speak to us, Eleanor?
Chair, I just thought, I couldn't think of any way to weave it into the agenda, but I just thought you might like to extend congratulations to the Fossway School in Westfield, which has won a national award for the quality of its religious education.
Well, thank you very much for sharing that with us, and obviously we do offer our heartiest congratulations to them. Thank you. So, on that positive end note, I'm going to formally close the meeting. Thank you everyone for your attendance.